بسم الله الرحمن الرحيم. كل سنة وحضراتكم طيبين بمناسبة شهر رمضان الكريم. Welcome in this first meeting of Egyptian Society of Nephrology and Transplantation CME meetings in Ramadan, the holy month. This meeting will be led by Transplantation Chapter, which is headed by Professor Ayman al-Rifai. Professor Ayman al-Rifai is the Professor of Nephrology and Transplantation, Mansoura Urology and Nephrology Center, and he is the President-elect of Egyptian Society of Nephrology and Transplantation and the head of Transplantation Chapter in the Egyptian Society of Nephrology. Together with Professor Ayman, we have today Professor Muhammad Subh as a moderator of this great meeting. Professor Muhammad will be introduced by Professor Ayman, and he is well known for all of us, and I would like to thank him very much for his continuous support and his continuous attendance and sharing in these meetings since our start last August. Our speaker is Professor Ahmed Halawa, and we will discuss about the pre-transplantation preparation. Before I leave the floor, I would like to welcome all the attendees and all our attending professors. Professor May Hasaballah, the head of Egyptian Society of Nephrology and Transplantation. Professor Faisal Shaheen, the past head of MESOT. Professor Tariq El-Baz, the past president of Arab Society of Nephrology and Transplantation. Professor Said Khamis, Professor Tariq Tantawi, Professor Hani Hafiz, the past president of Egyptian Society of Nephrology and Transplantation. This seems to be a very rich meeting, and we are all would like to start this meeting, and I will leave the floor to Professor Ayman and Professor Muhammad to lead the meeting and start. Please, Professor Ayman and Professor Muhammad, take the floor.
Thank you very much, Professor Yasser, for your kind introduction or for your huge effort in preparation and of the meetings of the CME. الصوت بتاعي واضح الأول معلش.
Very clear.
I'm not sure.
واضح.
Okay. It is very clear. Go ahead.
First of all, good evening, everybody, and Ramadan Kareem, and wishing you all the blessings of the holy month. Wishing the month. I think actually we are lucky that we have tonight two eminent and
sound is difficult.
Professor Ayman, I think you had a difficult connection.
with it's clear.
Yes, now it's clear. Please keep a good connection.
Should I repeat?
Yes, please.
No, go ahead.
Okay. First, let's mention why we select this issue to be discussed tonight. I think, as we all know, that patients with end-stage renal disease have significant comorbidities. And so it's important that potential kidney transplant recipients are carefully evaluated in order to detect and treat any coexistent illnesses. These illnesses could affect the perioperative period and, most importantly, the outcome and the survival after transplantation. So pre-transplant evaluation is an important process to distinguish suitable candidates from ineligible end-stage renal disease patients. So the goal is to anticipate and minimize post-operative complication and to prolong the kidney transplant survival. I think we should not concentrate only on the matching and to be aware about the rejection. There are a lot of comorbidities that should be evaluated. At this point, I will leave the talk to Professor Ahmed Halawa. Actually, Professor Halawa is not only a smart transplant surgeon, but he's, I think, one of the figures in medical education. So I think he's going to address these comorbidities and issues and how to evaluate it thoroughly prior to transplantation. Please, Professor Halawa.
Thank you very much, for this kind of introduction, and I wish you, a lot of blessing in this blessed month of Ramadan. Yes, actually, we shouldn't focus on the APO compatibility and HLA and just do straightforward chest X-ray and some blood test to make sure this patient is eligible for transplantation or fit for transplantation. But the situation is even more complicated than this. And I will explain to you later on why we have chosen this topic, because we have been bitten hard, and I'm sure everyone has. We had few disasters over the last 20, 25 years, which these disasters you will never forget. This actually, when it happens, it will recall for a review of your protocol, review of your practice, review of your thinking about transplantation. And you need to understand more about the CKD patient heading for transplantation. So the talk is in two parts. Today, you will hopefully will finish part one. And I'm sure at the end of part one, you'll be more confused than me. Of course, my name is Ahmed Halawa. I'm a transplant surgeon. And I would like just to highlight, working up a recipient and donor is my job as a transplant surgeon, because the mortality will be my mortality, morbidity will be my morbidity. This is why surgeons, transplant surgeons in UK are heavily involved in the work of donor and recipient, and even the tissue typing and cross-match. So the objective of this talk, of course, indication and contraindication of transplantation. This is quite straightforward. You will enjoy the first 15 slides because nothing fancy. But assessment of transplantation, this is where we'll start debating, and this is where we'll start confusing you, as I am confused. So simply, indication of transplantation, every chronic renal failure patient, end-stage renal disease, is considered for renal transplantation, unless contraindicated. All of us agreed on absolute contraindication. I don't need to repeat it, but there are some variations between centers, but we stick to our rules. So active infection, severe cardiac disease, recurrent malignancy, advanced cirrhosis, history of non-compliance, psychiatric illness, severe lung disease, aggressive recurrent native kidney disease, and obese patient, morbidly obese patient. Contraindication, again, relative. Treated malignancy, of course, there is, a cancer-free interval required after each malignancy, but it depends on the stage of cancer, the type of cancer, and the response to treatment. This applies to most of the cancers except the non-melanoma in situ carcinoma, skin and cervix, which where you can excise them, treat them, and transplant them. And I have done few like this where basal cell carcinoma and in situ carcinoma discovered and excised at the time of the operation. Chronic liver disease is a relative contraindication, which especially if it's due to hepatitis B and C, because we know that we can treat it with the new treatment. And even without any treatment, if the treatment was unsuccessful, which is unlikely these days, it still can be transplanted because the benefit outweighs the risk. Cardiac diseases, and this is a hot topic for today. All patients over the age of 50 or those of history of diabetes must have ECG, echo, and stress cardiac test. A history of a positive stress test or a history of ischemic heart disease must have cardiology evaluation in the view of coronary angiogram prior to transplantation. And this is the topic for debate today. And I'm sure you will be debating this statement at the end of the talk. Still, on the relative contraindication, HIV is not any more absolute contraindication. Still, we transplant HIV patient, but we have certain criteria to be fulfilled before transplanting them, basically related to the helper T count. Should be more than 200, absence of viral load by PCR, response to treatment, available treatment, no drug resistance, and no extracutaneous Kaposi sarcoma. We know the primary xelosis, type 1, is relative because type 1 has to be transplanted with the liver. But type 2 is different. Type 2, the liver transplantation is not indicated in this case, but kidney transplantation gives variable results. We have experience with one patient, type 2, transplanted successfully. It was a nightmare to prepare this patient for transplantation, but the transplant is working very well so far. For completion, the relative structure, genital urinary abnormality or recurrent UTI should be sorted by urology consultation. Past psychological and psychiatric abnormalities, of course, we'll have to make sure that the patient will be compliant with medications. Aortoiliac disease. In the textbook, we have to refer this patient to the vascular surgeon to correct the problem of aortoiliac bypass. If you look at this, this is aortoiliac disease. Will you transplant this patient? So it will be, you know, this session is an interactive session, basically. Yes, look, the problem is not only the arteries, but also he must have coronary artery disease as well. Both are closely associated, both are closely linked. Instead of sorting out the leg by bypass, also have to think of the heart. Not only that, technically, if you look at the disease vessels, they crush completely when you apply clamps. So again, we're making it worse. Why not have dialysis? Dialysis is a better option rather than dying on table. So these are standard workup: history, physical examination, laboratory investigations, the APO testing, HLA matching, cross match, full blood count, virology, including HIV, hepatitis, chest X-ray, cardiac clearance. Other tests may be required. It depends on the indications. There are exhaustive lists of these investigations, but every patient should be individualized. Most importantly here, to work as a team. Team means good communication. There's the word or the letter I does not exist in transplantation. I transplanted, I did. I does not exist, but we work together for the patient's benefit to get the best outcome. Is not one-man show. And I will give you a brief about the journey. CKD patients coming for transplantation. The objective destination is to live longer, better quality of life, and cost saving. How? Through kidney transplantation. They get kidney transplant. At some stage, they crash. Why? Cardiovascular causes. And I'm very grateful to one of the pharmaceutical company which provided me with this slide, which I will never be able to make myself. And if you look at here, graft loss, death with functioning graft is commonest cause, and cardiovascular diseases accounts for 40%. This is the highest rate, this is the most common cause of death with functioning graft. So every attempt will be focused to clear the heart. Cardiac clearance is important. And this is where the debates are. The top story is the very distressing story I explained to you early on at the beginning. A 38 years old CKD patient on hemodialysis, secondary to unknown etiology. He's 38, hypertensive, but well controlled, non-diabetic. He has cardiac clearance, ECG, echocardiogram, and stress ECG at the stress test. Seen by the anesthetist and cleared as well. Unfortunately, he died on table, had cardiac arrest on table at the time of transplantation before sticking the knife. To make the story even more dramatic, he came driving. This actually triggered us to look carefully about the cardiac clearance. Was it good? If the echo and the stress echo or stress ECG are enough, why 38 years old patient dies on table? And the cause of death was massive MI. Another thing we see day to day, quite common, many of our patients who have evidence of reversible ischemia on myocardial perfusion imaging had completely normal coronary angiogram. Strange. So how many patients had coronary angiogram for no reasons? How many patients being subjected to the risk of contrast, however small, and the risk of the intervention? Must be something wrong regarding the sensitivity and specificity of the cardiac tests. This triggered us to look at the cardiac clearance, cardiac investigations. Cardiac evaluation, this is what other centers do. ECG, start with, the stress ECG, echo, the stress echo, myocardial perfusion scan, coronary CT angiogram, coronary artery calcium scoring, coronary angiogram, and cardiopulmonary exercise tests. All these tests are available on our centers, and different cardiologists perform different cardiac clearance. We decided after this incident to assign one cardiologist only to look after CKD patients and clear them from the cardiac point of view. You know, marriage is quite stressful. This guy is asking for help. And the same for the heart. Cardiologist. Cardiologist is an important creature in the jungle of transplantation. We need cardiologists to contribute to your unit protocol and future referral. Not many cardiologists, only one or two who are interested in cardiac diseases in CKD. This will give them the chance to develop the experience. And you will know why, because it's never been straightforward. This slide is very important. It summarizes the different tests we perform and which one detects cardiac abnormality in the preclinical stage, which is our target. As you see, myocardial perfusion scan detects early, and also the echo and MRI scan. Look, ECG, when the damage already happened. So to be honest, ECG, most of my nephrological league will not look at it because we'll go far further down the line. I would like to remind you that gadolinium-based MRI scan is contraindicated in patients with GFR below 30. Of course, this patient you will never see in transplantation because they are not candidate unless GFR is 15 and below. For diabetic, 20 and below. Exercise testing. So we do dynamic and static. The dynamic, which is exercise testing, there are certain contraindications. Patient unstable angina, you could kill him. Decompensated heart failure should be excluded from the outset. Uncontrolled hypertension, he will be sent back. Many patients become very stressed, very anxious. On the day of the test, blood pressure is high. Will be sent back straight away to us to control his blood pressure. Severe pulmonary hypertension, because they're hemodynamically unstable. Some relative contraindication like mild aortic stenosis, but severe aortic stenosis is contraindicated. Hypertrophic cardiomyopathy, again, is a relative contraindication. This is Sheffield City Council, and this is our protocol. It's very simple, but to be honest, it's not efficient enough. But there is no way to improve it. And I will tell you why later on. We classify patients to low risk, those below 50, asymptomatic, and non-diabetic, ECG and echocardiogram. Remember, the guy who died was 38 years old. And he had more than this as well, in spite of that he had cardiac arrest on table. High risk, more than 50, diabetic. In addition to the ECG and echo, we'll perform myocardial perfusion imaging as well to detect reversible ischemia. If he has reversible ischemia, we'll do coronary angiogram and intervention, angioplasty, or bypass if needed. If irreversible ischemia, which will be shown as a fixed perfusion defect, echocardiogram is enough to check the ejection fraction ratio and also to check the myocardial contractility. Of course, valvular lesions, the size of the myocardium, all other things. Very high risk, who are definitely symptomatic. We'll send them straight away for coronary angiogram and intervention. Fine, so this is the first of the stress tests. How good is exercise ECG? You can see even in normal population, exercise ECG has moderate sensitivity and specificity, even when adequate exercise capacity and 85% of the target heart rate is achieved. This is a normal population. What about CKD? Sensitivity is 36%, so very poor, especially those on dialysis. Because they cannot do the exercise. They just go further. CKD patients have impaired heart rate response to exercise and frequently abnormal baseline ECG. This makes interpretation of the standard stress ECG is quite difficult. So the ECG is abnormal from the beginning. Not only that, in advanced CKD, the ST segment is not significantly different from those with less severe CKD. You can't tell the difference even if you made the treadmill exercise longer. Therefore, we stopped completely the exercise ECG. It's quite cheap, but as you see, not reliable. We have this death 10 years ago or something. Look like to have another death or a young lad because of inadequate and less sensitive test. Next one, it's myocardial perfusion imaging. Of course, interpreted by the cardiologist, not by the transplant team. But we need to know the basics of that, because this will lead us to something else later on. It's being done in 3 axes: short axis, vertical axis, and horizontal axis. Basically, it compares the image after stress with that one at rest. And you can tell clearly this is normal, mildly abnormal, severely abnormal. On myocardial perfusion imaging or scintigraphy, it can demonstrate myocardial infarction as fixed defect at rest and on stress. So there is an area of the heart is not perfused, both at rest and after stress. But reversible ischemia, perfusion defect on stress, which does not exist at rest. And this is where we refer this patient for coronary angiogram. Unfortunately, maybe 20% of our patients will come back with normal coronary angiogram. Let me dig down to the data further. A meta-analysis of 12 studies of potential renal transplant patients showed that the presence of reversible ischemia is associated with 6-fold increased risk of myocardial infarction and almost 4-fold risk of cardiac death. The fixed defect, which is the presence of myocardial infarction, is associated with nearly 5-fold increase of cardiac death. So it looks like the picture is not that gloomy, because myocardial perfusion scan helps prognostic and also patient counseling. If it shows something like this is an indication of possibility of adverse cardiac event. The risk of myocardial infarction or cardiac death are almost around 1 to 1.5%, with a negative predictive value more than 98%. So it looks like it's a good negative test. You can stress the heart by exercise or pharmacological. What we do is pharmacological stress. It's easy. Remember, we avoid exercise because they can't do it. CKD patients have limited ability to exercise. If you look at the sensitivity, is 87% or 89% for exercise and pharmacological stress, specificity 73-75 in detecting more than 50% coronary artery stenosis in patients without advanced CKD. But I will ask question and will answer this question later on. If the presence of perfusion defect correlates well with the symptoms, we'll see this later. And this is a meta-analysis and of the myocardial perfusion scan showed the sensitivity of 67% in CKD, in CKD patients, and specificity of 77%. They concluded here, the stress myocardial perfusion has imperfect diagnostic accuracy in this specific patient population, in CKD patients, but still valuable non-invasive modality in cardiovascular risk assessment. So it is an imperfect diagnostic accuracy. So it's not terribly accurate. This is the first, this is the second confusion actually. Why myocardial perfusion scan, in spite of we rely heavily on myocardial perfusion scan, why they are not so sensitive? Why they are not terribly specific? Because of these patients have, CKD patients have hemodynamic and anatomical abnormalities, which could impair the diagnostic accuracy. Don't forget the left ventricle is enlarged, there's left ventricular hypertrophy. This can compromise the detection of small or mild perfusion defect, decreasing sensitivity of the test. Not only that, large left ventricular cavity due to chronic volume overload, because of the hemodynamic circulation secondary to the fistula as well, can increase attenuation defect, especially at the inferior. And this is what we are getting constantly. However, there is diminished perfusion in the inferior wall, and usually attributed or could be artifacts. And if they are not sure, this patient will get coronary angiogram as free lunch with its complications. When you stress CKD patient, the hypertensive response to stress is different and can create ischemic dilatation and artificial perfusion defect in the absence of significant CKD. When you give the isotope, it looks like the perfusion of the isotope as well is affected by the endothelial dysfunction in these patients. This again decreases the sensitivity of the myocardial perfusion test. These patients in between dialysis are volume overloaded. Subsequently, elevated background activity for increased lung uptake. And this again models the image quality. So it looks like myocardial perfusion scan could be good in normal population, but is not ideal in CKD patients. They are different group of patients. Fine, let us move on to another confusion. Stress echo. Dobutamine stress echo. Some centers, attached to us use it. The whole idea is when you stress the heart and apply echocardiogram, you detect wall motion abnormality. This is an indication of ischemia. Also, the echo is helpful. It assesses the ventricular size and function, the valves, calcifications, left ventricular hypertrophy. When you look at the sensitivity, it's moderate, around 80%. Why is moderate 80%? If you look at the confidence interval here, is wide. But still, we do it. But the good thing about it is it's been shown that abnormal stress echo in CKD patients associated with poorer prognosis for cardiac events and overall mortality. But the good thing, negative one, is associated with low incidence of major adverse cardiac events. You can tell clearly so far that these tests are so far good negative one, but not perfect positive ones. I'm not expert in this, but you can tell there is difference between rest and stress here. This is cardiologist. This is for the cardiologist to identify to us. So, regarding the stress tests I discussed, no stress method quantitatively measure the needed blood flow to the cardiac muscle. We only detect imbalance of blood flow between regions of the left ventricular muscle, which are beyond the capabilities of the arterioles to fully compensate. So it looks like a comparative flow rather than an absolute flow. If you remember, it compares the flow on stress compared to at rest. Fine, let us move now to angiogram. Coronary CT angiogram. It was a fashion in 2016, but I think fell out of favor recently. It's not an invasive test with high negative predictive value like the other tests. Reliable in ruling out significant coronary artery disease in symptomatic patient with low to intermediate risk of CKD in general population. So negative test, less likely to have coronary artery disease. In 2016, the National Institute of Health recommended coronary CT angiogram as the first line investigation for all patients with angina symptoms or ischemic ECG changes, regardless of the pretest probability of coronary artery disease. But we didn't do it. And I will tell you why shortly. Coronary CT angiogram has high sensitivity, well done, 93%. But here is the catch, moderate specificity in CKD patient for diagnosing obstructive coronary artery disease in RCTs. The poorer specificity is likely attributed to the high calcium burden in coronary arteries without obstructive coronary artery disease. CKD patients have very high coronary artery calcium scores. And this coronary artery calcium score may not have underlying significant stenosis. They suggested that why not to do coronary CT angiogram for those who has zero, low or low calcium scoring. But why to do it in the first place? If they have zero calcium scoring, less likely to have coronary artery disease. So we're not sure. And this is how it looks like. CT coronary angiogram, and you can see calcified plaques here. But the question is, if there's any obstructive lesion, if this artery is stenosed or just calcification. We mentioned early on, calcified arteries is not uncommon in CKD patients. I will explain this further in the next few slides. So the role of coronary CT angiogram in detecting coronary artery disease in patients with CKD is still uncertain. So it's blurred, vague, unclear. Next one is coronary artery calcium scoring, which I mentioned early on. This is a very quick non-invasive screening test, low radiation exposure, even no contrast. It measures only absolute calcium in the coronary arteries. Coronary artery calcium score of 0, this is 100% sure, but excludes significant coronary artery disease with excellent negative predictive value. Right? How reliable it is in CKD patients. In end-stage renal disease, there is increased medial calcification, what's called Monckeberg sclerosis in patients with end-stage renal disease, likely to cause reduced diagnostic accuracy of coronary artery calcium scoring. If you look at the specificity here, it's 53%. So we can see all these tests I mentioned have low specificity. This Monckeberg sclerosis, which is quite common in CKD, does not contribute to the development of occlusive coronary artery disease. We thought, fine, let us do this as a part of the scoring system or risk stratifications for those of end-stage renal disease going for transplantation. So the role is still uncertain regarding coronary artery calcium scoring. And this is a picture which explains further what happens in CKD patients. This is Monckeberg sclerosis. The media is calcified. This calcium plaques here, this calcium. What about in atherosclerosis? A subintimal lesion. So the disease is different. Again, we're dealing with different group of patients. And this is how it looks like. You can see no contrast, just score the calciums. And also, it's important to know that it's age-related. Score of 20 in 38 years old is considered high, but won't be considered high in 70 years old. And unfortunately, there is no standardization of the scoring system. At present, the role of coronary artery calcium scoring in this patient population is far from clear. Adjustment of traditional cutoff score may be necessary. Fine. Invasive coronary angiogram. Do you think coronary angiogram will sort it? Because we used to call invasive coronary angiogram, which is a catheter coronary angiogram, is a gold standard diagnostic technique for anatomical detection of coronary stenosis. And I highlighted anatomical. Why? We know later on, it does not test the function. It's anatomy only. But the anatomy could be correlated with the function. But is it 100% correlation? Of course not. It is an invasive, costly test. Requires contrast. However, we used to scare about, from the contrast given coronary angiogram, it's only 50 mL, but still contrast. You still worry if you have pre-dialysis patient heading for coronary angiogram that he will land on dialysis. G4 15, not yet on dialysis. You might make him dialysis patient after contrast unless care being taken. It is an intervention. Risk of major complications are rare, around 2%. I explored and I opened up many patients in my career after coronary angiogram because of the local complications. Low mortality, but it's still a mortality. Fine, okay. So how good invasive coronary angiogram is? The prevalence of angiographically severe coronary artery disease, which is basically defined as 70% reduction of the lumen. How common? It's quite common. Reach up to 60%, even higher. If you consider liberal definition, if you drop the luminal reduction to 50%, you get more. So coronary artery disease is very common in renal failure patients. But the problem is the presence of anatomically significant defect does not always correlate with the functional significance of the stenosis. Godak and colleagues found that coronary artery disease was associated with significantly increased risk of major cardiac event. I'm starting confusing you now. Only among high-risk transplant recipient without diabetes. But what about those with diabetes? There's no difference, which to me, strange. So what do you think? Is diabetes a good disease, prevents and protects against cardiac disease, or the coronary angiogram itself is not a sensitive test in this group of patients? So if you can say that in non-diabetic, if you have abnormality with a coronary artery disease, more likely to get cardiac event, but in diabetic, no difference between those who has coronary artery disease or no. I would like to add more confusion. the long-term prognosis of non-diabetic patients with CT, with coronary artery disease was comparable to the diabetic patient with or without coronary artery disease. So it looks like the test itself, the coronary angiogram, is not sensitive in those diabetic patients with chronic kidney disease. And if you look at our protocol I presented early on, any diabetic, regardless to his age, should have coronary angiogram. And if you look at the American Society of Transplantation protocol and British Transplantation Society protocol, diabetic should have coronary angiogram. Looks like we misunderstood the test, sensitivity and specificity of the test, and we misunderstood as well diabetes. And this adds more confusion. I like this diagram very well because it's very simple and explains where the problem is in the coronary arteries. 90% of the stenosis below the takeoff of the circumflex artery. This is in the left main coronary. So this part is vulnerable. And this is a real angiogram, coronary angiogram, and shows this is circumflex, and this is the disease here, is below. Are you confused? I am confused. I don't know which test to do. It looks like there's no perfect test. I'm dealing with uncertainty, lack of clarity. In a way out of this. I will explain this later. I'll give you an answer, hopefully a satisfactory answer, but this is what we have. I'm moving now to a fancy test. We do it, still getting experience with the test, which is coronary cardiopulmonary exercise testing. Many publications about this test everywhere. In non-renal and renal. And this is a cardiopulmonary exercise test. Basically, we call it the bike test, as if you are in the gym and getting exercise on a training bike. To be honest, this is a good test. And I will tell you why. The principle of this test is to measure the physiological reserves and the function capacity of the heart, the lung, the muscle, and the nervous system as well. The neuropsychological response during exercise. We use this test when we're not happy with the patient clinically, but all other perfusion, myocardial perfusion, and echocardiogram, and up to coronary angiogram is equivocal. The background of this cardiopulmonary exercise test is basically surgery is a major stress. And during stress, the individual has to increase the baseline oxygen consumption. In order to increase the oxygen consumption, you have to increase the oxygen delivery. And this is a point here. This is a critical point. Oxygen delivery, you need good muscle respiration, you need good heart, you need good lung. So it tests the three systems together. But for me, as a transplant clinician, I need to see three parameters. Usually this test, the report comes 10 pages long with a lot of diagrams which I can't read. To be honest, I'll be looking into the three parameters to make judgment, which this is what really matters for me as a clinician. Ventilatory anaerobic threshold, the peak oxygen consumption, and ventilatory efficiency for carbon dioxide. And I will show you this nice diagram, and this will tell you how good the test is and how different diseases affect the exercise, cardiopulmonary exercise test. Is a 3-gear system. These are the 3 parameters I'm always interested to see. The anaerobic threshold is less than 11. This is risk of complications after major surgery. Peak oxygen consumption less than 17 mL per kg per minute associated with further cardiac events and all-cause mortality. Ventilatory efficiency of carbon dioxide more than 39 cutoff, predicting 90 days mortality. This is quite promising test. It could solve the lack of specificity of non-invasive tests. But again, we need clinical evaluation of the patient exercise performance. And also, we need to discuss it together as a team. We'll come to this later. In the past, I used to think that patient who had revascularization is being sorted. So the problem being corrected. So how good is revascularization? Coronary revascularization decision for those category of patients is a dilemma for clinicians because the high baseline risk of mortality and further cardiovascular events, they are high-risk group. Unfortunately, this high-risk group being excluded from nearly all randomized trials evaluating outcomes of revascularization. So it's not clear whether revascularization will help or not. Let me add more spice. These populations, CKD patients, differ from general population regarding the composition of the coronary plaque and the behavior. And a lot of research have debated about this. The accuracy of the non-invasive testing, which we mentioned early on, also the response to surgical and percutaneous revascularization. Why? Because the disease is different. The disease is different. Therefore, finding for general population cannot be extrapolated and implied to CKD patients. The Halawa study, which is a very elegant study, it's an autopsy-based study done by a Japanese group, published in 2010, demonstrated clearly that patients with end-stage renal disease have greater coronary calcification and medial thickness compared to the more fibroatheromatous plaque in patients without CKD. Again, you cannot apply what happens in normal population to CKD patients regarding the revascularization. Let me make it even more worse. Cameron and colleagues suggested that coronary artery disease outcome post-transplantation are not affected when optimal medical therapy is used instead of coronary revascularization. So optimal medical treatment in UK means aspirin and statin. That's it. I don't need to revascularize these people. I'll just give them aspirin and statin. Mansingh and colleagues reported similar 2-year survival, where coronary revascularization 77%, no coronary revascularization 81%, but they excluded triple vessel disease. There's another confusion, I'm sure. Even we thought that coronary angiogram will help. It does look that we don't know whether it's useful or not. It could be just medical therapy, optimal medical treatment. In conclusion of this confusion, all cardiac investigations are good negative tests with excellent negative predictive value, but low to moderate positive predictive value. High sensitivity, but low to moderate specificity. Coronary artery disease in CKD patient is different from coronary artery disease affecting normal population. Therefore, the investigations and outcome of the treatment are different as well. If you look at these studies, the studies are insufficient and full of confounding factors, like excluding triple vessel disease. Short-term follow-up, because the last study I presented was 2 years follow-up. Here is the point I'm trying to make, and emphasize the slide I presented at the beginning. Nothing called I. There is we. MDT approach is essential when there is a lack of clarity and in the presence of uncertainty. Also, is important to counsel the patient properly, especially in the presence of blurred picture. And I think till we have clear evidence, we have to work together rather than individually to make a decision. Surgeons, nephrologists, transplant coordinators, tissue typing lab, renal pharmacists, renal psychologists, anesthetists, and cardiologists. This might reduce the bias and clear many of uncertainties. I'm moving to something different. This is part 1, native nephrectomy. Because some clinicians think that native nephrectomy is required prior to transplantation, but it has certain indications. Infected stones infected reflux. Remember, uninfected reflux does not require nephrectomy. Other polycystic kidney disease, massive, recurrent bleeding, recurrent infection, acquired cystic kidney disease for the risk, if there is risk of malignancy, because this is a pre-malignant condition, patient with heavy proteinuria, intractable hypertension. But I highlighted the most important indication here, failed medical nephrectomy for the indications listed above, except large size for other polycystic kidneys. We should try medical nephrectomy first. Except for other polycystic kidneys. This picture of the other polycystic kidney at the top, and this is acquired cystic kidney disease at the bottom. Other polycystic kidney in our practice in UK, if both kidneys or any one of them goes below a line drawn between the iliac crest, is a large kidney. If both are large, this is an indication of native other polycystic nephrectomy. We perform only one side at a time. He may not require, the patient may not require the second nephrectomy. And normally I remove the large kidney because more likely to have complications later on. On the right-hand side, both kidneys above the line drawn between the iliac crest are not considered large. Transplantation can be performed unless the patients complain of bleeding, infection, or severe intractable pain. I would like to thank you for listening, and especially late night in Ramadan, and hopefully you enjoyed my confusion. We'll see you in part 2.
Thank you very much, Professor Halawa, for this excellent overview about the pre-transplant assessment of kidney transplant candidates. Actually, you elegantly and comprehensively addressed that special attention should be given to the cardiovascular evaluation, because as you mentioned, and as we all know, that the leading cause of death with functioning graft after kidney transplantation is the cardiovascular disease. In this regard, I would like to mention that we recently, 2 months ago, reported our experience in Mansoura about the death with functioning graft among 3,000 kidney transplant recipients. And we found that after multivariate analysis that the common cause of death with functioning graft was the cardiovascular disease. It was 40%, followed by the infections. It was 29%. And the third cause was post-transplant malignancy. It was around 14%. So the comprehensive evaluation of the cardiovascular status, I think, as you mentioned, is very important, especially in high risk group of patients. And I think it's also worth to mention that this evaluation should be as efficient and cost effective as possible, I think. Now I'm honored to have our dear professor and my role model in nephrology transplantation research, Professor Muhammad Subh. I will leave now the moderation for him to give his valuable comments. Please, Professor Subh.
Thank you very much, my dear friend Ayman. Thank you very much, Dr. Yasser Abdel Hamid, for your great effort you always do.
Thank you, Professor Muhammad.
Of course, my great thanks for my friend, Dr. Ahmed Halawa, for his great effort in his training program and the transplantation programs and the education activity, and for this very interesting, very informative, and very puzzling and confusing, a big amount of information. The point is that the problem, I'm going to evaluate patient for coronary illness. There's, as you presented very elegantly, a lot of investigation to be done. Some are easy to do, available everywhere. Others are not available. But of course, you highlighted that every transplantation program should have a cardiologist. And as you said, not at large, but you have to have one or two dedicated cardiologists attached to your program to feel and to taste the specificity of cardiovascular problem in CKD patients, which are different from the general population. The confusion is double. Number one, what is the best test to assess this patient? You need a lot of work, a lot of investigation to say this patient need or not need interference. But when you started to talk about the value of reperfusion of coronary stenosis coronary, the difference between those operated upon and those not, the deal was not that big. This added to the confusion. How deep, how big effort I have to do in evaluating these patients whom are, I will say, asymptomatic cardiac-wise and on dialysis waiting for transplantation. Why I do a big effort like this, and at the end I will say this patient need a reperfusion or not, and if he perfuse versus not perfuse, the deal is not that different. So there is a confusion. To me, I found that echo and stress echo is valuable test, as you said. Echo will help me to evaluate the function, myocardial function. If there is slow motion abnormality in the myocardium, I can assess if there is pulmonary hypertension. I can assess if there is tight stenosis, tight stenotic lesion. And if I do stress, it seems it is good test. So if I'm going to select a single test among this dilemma of tests, I will select this echo and stress echo. This is my quick comment, and I will leave space or leave the floor for my colleague to start giving their opinion, to start discussion in this very elegantly presented lecture.
As a matter of fact, Professor Subh, there is no difference between all these tests except the exercise ECG is poor sensitivity and poor specificity.
Yeah.
But the rest of the tests are equivocal. So
Right.
good sensitivity and poor specificity.
Wow.
I am in favor, and what we normally do here is myocardial perfusion scan for the above 50 and stuff like that. But again, they're no different from the stress echo.
Yeah.
Maybe, when we widely employ the cardiopulmonary exercise testing, will give us more comprehensive answer because it tests the lung and the heart and the muscle together.
Yeah, this is a good test. Yeah.
But again, is not widely employed, and we apply this for high risk when we don't know what to do. Patient looks very poor in front of us, but the myocardial perfusion scan is satisfactory. The echocardiogram is just borderline. So shall we transplant? Shall we stick it on the list? Still, we have to remember this guy who died on table is 38 years old. Or shall we do exercise pulmonary test? If we are not sure, we'll do the CPET test. Sometimes the CPET test comes with more confusion as well. So is an aerobic threshold of 11 is good? Just at the cutoff. Again, it looks like, you know, in order to be 100% sure, we have to do all tests together. The stress echo and myocardial perfusion and coronary angiogram. This is totally insane. We can't do this. So this is, you know, the way out of it is to discuss it all together with the cardiologists and to see what's the best test we can perform, we can ask for, and address this to the patient as well, because it's important as well to include the patient in our discussion. So the answer is still, I don't know, and I'm sure no one knows, but it looks like maybe in the future, we can have more studies on CKD patients. We have more understanding of the disease. We have more understanding of the cardiac disease in CKD patients because it looks different from the cardiac disease in non-CKD patients. This is different group of patients. And I mentioned early on, you know, most of the studies excluded the renal failure patient. No. So we cannot imply what been reported in non-CKD patient to CKD patients.
I think, Professor Halawa, that to find a way out for this confusion, that we have to do two things. Number one is to stratify our patients regarding the cardiovascular risk. So we have to tailor the test for for each category. Number two, that we should have a clear algorithm for performing all these cardiovascular evaluation. So patient stratification followed by algorithm to follow. Otherwise, we will have a confusion between all these tests.
Yeah, I mean, I totally agree with you. We have algorithm, and when I worked in Newcastle, I think we spoke together yesterday about Newcastle scheme or the risk stratification, and when I worked in Liverpool, the same as well. Every unit has its own protocol based, all these protocol based on disasters, you know, and the protocol when I was in Liverpool, because of when we started the pancreatic transplant a long time ago, we had high mortality because of the cardiovascular events. So we stopped the program and started to look back why this patient died, like shortly after the operation. So we have to design a protocol. But again, different protocol, different places. But I think in addition to this, the protocol should include the cardiologist who is expert to give an answer. And also, rather than referring the patient to millions of cardiologists, we should have one or two cardiologists we can rely on. At least they can get experience as well with the disease, because CKD patients are different from normal population. You know, I mean, honestly, the answer is not clear, you know, and it's all about MDT team, group discussion. No I, but we.
I think one big difference between your transplant candidate and our here is that you are transplanting elderly patients. You have no age limits in your patients. So as we know that the cardiovascular diseases are more common among elderly patients. But I think in our patients, this cardiovascular risk is not that great as in your population. So I think you are confronted with more elderly patient with more cardiovascular diseases than we are confronted in our society or our
Yeah,
population.
but I think in your society as well, your cardiovascular disease start at a younger age because of environmental factors. So maybe the environment here is different, but again, it's well known that people from Middle East have small coronary arteries, more likely to be ischemic heart disease at younger age, also diabetic and hypertension as well. However, in the population here in UK and Europe are quite different. Diabetes is not that common to the Middle East. Also, ischemic heart disease. Simply when I go to work, I used to go on a bike, and I found most of my colleagues on a bike as well. So it's a cultural things, but in the Middle East, I think there's big cultural difference.
Again, Dr. Ahmed.
Ayman, Professor Ayman.
Yeah. Again, Dr. Ahmed, you said that when they compared those operated upon and those left without interference, the difference was not that great.
Significant.
I'd like to ask two questions. Operating on patient while he is on dialysis versus operation post transplantation. The risk of surgery, is it not more while if I operate while on dialysis? Is it wise to do transplantation first, then when the graft is stable, if he needs surgery, I do it? This is a question. What about a patient who shows coronary artery on imaging tool, but he is asymptomatic? The patient is asymptomatic, but he has coronary stenosis. We know collateral can compensate for stenosis. So if I have patient on dialysis, he is hypertensive, yes, but he is asymptomatic. He is 60 years, for example, but he is asymptomatic and have good effort tolerance. And I did this invasive investigation. I found the coronary artery, but is asymptomatic. Is it wise to go and do surgery?
No, actually, as a matter of fact, if you have perfusion, reversible ischemia on a myocardial perfusion scan, and patient, can go for miles walking.
Yeah.
Most likely, it will be declined coronary angiogram. We'll seek cardiologist's opinion. Any reversible ischemia should involve a cardiologist. And what will happen? He will put him in aspirin and statin rather than giving him coronary angiogram, because his performance is excellent.
Yeah.
But this is important for counseling. And we know that myocardial perfusion as well is not 100% specific in CKD patients, especially the inferior wall. It will show some perfusion defect in the inferior wall because of the size of the myocardium, because of the fistula, because of the hypertension, because of the response to stress, because of the background activity of from the lung, because of fluid overload. So most likely this one won't get coronary angiogram.
Yeah.
The coronary angiogram, the indication of coronary angiogram now has changed completely. Coronary angiogram in the view of intervention. Yeah. Because our cardiologist who does coronary angiogram, he's an interventionist. So if he finds a significant stenosis, he will deal with it. Sometimes the coronary angiogram comes with extensive disease, not amenable for any intervention, and he recommends him to be on aspirin and statin. Yeah. And this is where we discuss with the patient. Yeah. Give him risk of mortality, let's say 20% dying of a cardiac event. Are you interested to proceed? To be honest, if I'm an elderly person, 70 and above, and he's doing, again, because this what actually annoys me. Sometimes a cardiologist will write to me, he's fit for transplantation. Hang on a second, from the cardiac point of view, but you haven't seen the rest of the body. So he's 70 years old, he's doing well on dialysis, and has extensive coronary artery disease, not amenable for any intervention, so we cannot make him better. Why to subject him to transplantation and risk of death? And this is where we discuss with the patient. Fine, he's 70, you look well on dialysis, you're managing well on dialysis. Transplantation may not offer you a better quality of life, may not offer you survival. You may die with ischemic heart disease shortly after the operation. We have one patient from, from Indian origin who said, no, I would like to take the risk. Unfortunately, he took the risk and died 5 days later of massive MI. But again, for counseling, it's important to share the ideas with the patient as well and explain to him why you're declining him the kidney transplantation.
Good, it's very good, yeah. Wise discussion, wise decision,
Yeah.
Professor Subh, Professor Ayman, we have Professor Maya Hasaballah and Professor Tara Elbaz wants to comment.
Yes, please.
I asked Professor Halawa to review the chat. We have also some questions on the chat while we are listening to Professor comments. Professor Maya, please.
Professor Halawa, thank you very much for this presentation. I really learned a lot. I always thought that coronary angio was the answer to the confusions, but now it is confusing in itself. So I really do believe that involving a cardiologist, and not any cardiologist, of course, that has experience in CKD patients is very important. Until we get to know the exact steps that we can do, I think it has to be always a discussion thing between us all. Thank you very much for the presentation and for the confusion.
Sorry about the confusion, but this is reality. This is what we have.
Yes.
Yeah,
I can see that. Thank you.
Professor Tara Elbaz, please.
Yes. Once again, I'm really impressed by what you had to show us today and the terrible situation that we are facing. I too, like Professor Mai, we're not cardiologists, but we had strong belief that the eventual coronary angiography would be a solution to all the problem, where you showed clearly that it is not, particularly in diabetics, which are making a big part of the population that generally we are transplanting all over the world. I like the part about counseling. Since we have such a confusional state and we cannot really consolidate on the outcomes with some patients, how can this counseling be of help, or is just a kind of a way out for the transplantation team to be legally secured, or is it in favor of the patient by meaning to empower him in taking the decision with us whether yes or no? Can you please enlarge a little bit on this counseling?
Fine. Okay. I mean,
it depends also on cultural backgrounds and educational backgrounds of the patient, or like here in the Middle East, the family is always involved in taking decisions for the patient, and maybe the patient comes last in many scenarios, as we see.
Yeah, this will add complexity to the whole issue in the Middle East, where the population is collectively, but in the West is individualized. So basically, back to the question of Professor Tariq Elbaz, thank you for this question. Renal transplantation is not life-saving. It's mainly to improve quality of life. Of course, it improves quantity of life, you live longer, but we have option of dialysis. Dialysis improved. We know much better now compared to when we started dialysis 30, 40, 50 years ago. So dialysis is a good alternative option for those who are borderline or those who are not fit for transplantation. Transplantation may not sort out the problem, actually may trade the problem with another one. So patients who are not fit or cardiologically borderline may have disabling ischemic heart disease or myocardial infarction. So the quality of life is completely lost, after transplantation. And we have few patients who insisted to have transplant, and we were sitting on the fence. We transplanted them. They never got better. They regretted having kidney transplant. So counseling as well is important for decision-making, because patient is part of the decision-making here, with the decision-making process. To see whether, if you put the pros and cons to him and see where he goes, if he said, no, this is actually will save the problem, fine. Okay, I'm happy. I'm happy on dialysis. Don't have any trouble. I thought better to discuss it and better to address the dialysis option. Or I would like to happy with a transplant. It's better to discuss it. It's better to discuss transplantation option to see whether it's good for me or not. And sometimes they come with the conclusion that I know that I'm not fit for transplantation, but I wanted to discuss it first. And this actually happens after you do all the tests, all investigations, and you confirm, fine, your fitness is an issue. What do you think about staying on dialysis? This is what I thought. Yeah, I thought it's unfit. I'm not fit. And actually, usually, if a man comes with high ambition, usually the wife next to him, I told you, you're not fit. So it looks like it's a family decision as well to some extent. Don't forget, these days, a lot of litigations and complaints as well. So it's a partly defensive medicine as well, because we have to protect ourselves by documenting the discussion with the patients and make sure that he understands the pros and cons of any procedure we do.
From an ethical point, if the team has decided the unfitness of the patient, in spite that the patient wants to carry on the risk,
no, this is different, Professor Tariq. If he said, if we decided is not fit, there's no further discussion. What we do, we send him to a second opinion. Fine.
Right.
Look, in our center, we cannot transplant you, sir, because we think you are not fit, but you are entitled to second opinion. So I will send him to Leeds for second opinion, or Nottingham for second opinion. But we're not transplanting this guy because we decided that he's not fit. But those who are borderline, this is actually sitting in the gray zone, which
this is the one I'm talking about.
Yeah, the gray zone. You have to have the patient with you and see whether if he says no from the beginning, the story is finished and you close the chapter. But if he still insisted, we transplant him and you do your best to get him out of the transplant. He may or may not survive the transplant, but we give him the chance.
Right. Thank you very much.
Professor Dawla Bilal.
Yes, thank you very much for the very informative talk, Professor Halawa. Our life seemed before much simpler than after listening to this talk. And I want to confirm Professor May Hasaballos and Professor Tariq that we have to have involved cardiologists involved in our type of patients, the CKD patients, not his patients. To put an algorithm, as Professor Ayman Rafai asked, and this should be with the meeting. It should be a conjoined decision between him, this specialized cardiologist, and us. This is the only way to do it, because after what you explained, I don't think it is easy for us to take a decision alone. the cardiologist has to be involved medically and legally in this issue.
100% agree, and this is what we're doing.
Yes.
Because, and even the cardiologist wouldn't get involved. You know, in spite of the cardiologist being involved in the, you know, in the cardiac clearance of the guy who died at the age of 38 until still patient died. So
did he do angio before?
No. I mean,
yeah.
the cardiologist, these cardiologists actually, we try to, you know, stress echo, echo and stress ECG. We addressed these cardiologists that stress ECG is inappropriate in CKD patients, but I'm satisfied with the performance of this guy, and then ended up by dead patient.
Mm-hmm.
We forced the whole system to change, and if he requested stress ECG, and patient comes to me with the stress ECG, myself, I request myocardial perfusion.
Mm-hmm.
So, you know, any stress ECG will be ignored.
Right.
Thank you. Thank you, Professor Halawa. And excuse me, shake your hands about your start of talk by that transplantation. We should, not I. This is a very important point. Did you check the chat, or can I say the questions? Read the questions for
feel
you?
free. Yeah, I'm the chat in front of me here.
Yes, we have. Okay. First question.
Yes. We have more risk factors: diabetes mellitus, smoking, obesity. Of course, all these are risk factors. Yes.
So what to do in patients with abnormal perfusion tests with negative coronary angiography?
Nothing will list him for transplant.
Okay.
Because, you know, again, the coronary angiogram is anatomical, but this is what we have. You know, it's anatomical. It looks for the anatomy of the pathology, anatomical pathology. So there is no coronary artery stenosis. And we know that the myocardial perfusion scan is not 100%, so 70% and 70% specific. So we know 30% are missing from the specificity and sensitivity. So this is inherited with the test, and I explained to you early on why it is not sensitive, terribly sensitive, why it is not accurate with, you know, with specificity, because of CKD patients are different.
Okay, thank you. Another question from Dr. Muhammad Ibrahim. Coronary events are usually due to plaque rupture rather than spastic or constrictive lesions. Would this obviates the need for exhaustive testing in patients who have performance status clinically?
Good performance status.
I think it's not clear.
We have good performance status.
We have good performance.
Look, I mean, we have to stick to a protocol. So, you know, rather than, you know, we have to stick the algorithm that, as Professor Ayman mentioned, Professor Dowlat mentioned, Professor May mentioned, has to be a protocol rather than you go through a stepwise approach. ECG, echocardiogram, static echo, and then you do whatever. Stress echocardiogram or stress myocardial perfusion. And then you see the results. Because they could be asymptomatic. Remember the slide which I demonstrated that these tests sometimes pick up abnormalities in the preclinical stage, still not presented, but potential to cause trouble in the future. So what we're looking at to prevent the disaster, not waiting for the disaster to happen and then sort it out. The high risk group, because extensive atherosclerosis, in addition to medial calcification as well. So the coronary artery will look like a pipe, water pipe, rigid.
Okay. Professor Tariq Abbas, Professor Hani Hafiz wants to comment. Professor Hani, yes, Professor Hani, please.
Thank you, Professor Halawa, very much. It's a great honor to have you with us today. And my question is rather related to the overall risk of dying from coronary or from ischemic heart disease for CKD patient if they will remain on dialysis and don't do transplantation. And now, after your talk, we are also afraid from going to transplant them. So I think the risk is present anyway. I mean, if the patient will not go for transplantation,
Will have high risk.
He will die.
Yes. Yeah.
With a high risk. And if he goes with transplantation, there is, of course, a risk of mortality during the surgery, but the quality of life, if we overcome this risk, will be much better than if he continue on dialysis.
Absolutely.
So we as physicians, we have to look a little bit in a philosophical way to, as long as the risk is the same in both cases, why not to offer him a better quality of life, even if it is a little bit risky. This is my question, rather than
actually, I 100% agree with you. You know, we looked at transplantation, but I didn't look at the CKD patient. Of course, high risk of cardiovascular, events is higher, and the poor quality of life. They have poor quality of life. But what I refer to is the investigation of this patient is not sensitive enough to pick diseases. If we have negative tests, this is definitely reassuring that they won't have, or the chances of having cardiac complications quite minimal, up to 1 to 2%. But if the test is equivocal, this is where we need to think twice where he wants to go. But all the x-rays and the angiogram I presented, you can see that, they are on dialysis, but they're not transplantable. So basically, yes, transplantation is associated with better survival for those who can survive the operation and better quality of life. But we need to be very, very careful with investigating this patient. This is a message I would like to pass. It's not that walking in the park and you cannot apply what's been applied on general population to CKD patients.
Thank you.
The idea is not to deny them transplantation, but try to be more vigorous in terms of investigating them properly.
Professor Ayman is back. We still have many comments and questions in the chat, and we are 14 minutes to 2 hours of this meeting.
Yeah, we are running out of time, I think.
Yes, we have no time.
Everyone is exhausted rather than and confused also. So it's confusion and exhaustion. So I think, okay. I think now we came to the end of the first part. I think Professor Halawa for
Dr. Tariq Abbas would like to ask a question. Do you mind, Dr. Tariq Abbas?
Dr. Tariq Abbas wants to comment.
First, I would like to thank Dr. Halawa for this very nice talk, and I want to have just 2 comments. First, from our experience, and as Dr. Ayman mentioned, this with functional graft due to cardiovascular etiology is the commonest cause of graft loss post-transplant. Therefore, presence of extensive cardiac assessment pre-transplant is very important. So we need to have a cardiologist in the team. Now, when the cardiology assess the patient, if this is a simple consultation and in absence of any guidelines or routine work to be done, the patient will be managed as any general population. And as I understand from the lecture that this population is different completely, CKD is different from general population regarding diagnosis, management, prognosis, and everything. So we need clear guidelines. Otherwise, if this is a simple consultation, the cardiologist will manage as general population. We need routine to be done. For example, if the patient is diabetic and young, a lot of scenarios, we need risk stratification or at least something routine to be done whether the patient is symptomatic or not. Because if the patient is asymptomatic, this doesn't mean he is completely free clinically. Thank you.
Yeah, a very nice comment, Professor Tariq. Yes, up to the point as well. Yes, I totally agree with you. And this would not make the risk of death zero, I'm afraid, because you're dealing with, I used to call them half dead. You deal with half dead patients to start with. And actually, you operate on them, give them toxic drugs like immunosuppression as well. So this will increase the risk, cardiac risks as well. Renal failure is the worst disease you will ever have. You know, if you have coronary artery disease, can stented, angioplasty, whatever, coronary bypass, but once kidneys are gone, other system will go as well.
Professor Sobh, Professor Ayman, who cannot reject success, fortunately. Professor Faisal Shaheen wants to comment.
Okay.
Yes.
Welcome.
Well, I think Prof. Halawa, excellent talk, but still, you know, there is many issues which should be considered for the CKD patient. Usually they have atherosclerosis, usually they have hyperparathyroidism, which can affect their vessels. And probably if we go like what you said by textbook, by this test one by one, we will not get some patient which is suitable for transplantation. So it is very difficult task. We have, as Hafiz said, that we have to weigh things, either who's benefit more, either with transplantation or to keep the patient on dialysis. The other things, I was quite surprised to know that the patient which have DM is equal in risk like the non-DM patients. This is probably for me it is just a new, because we get used to investigate more the diabetic patient over 45 years if they are going for transplant, and less than 45 usually we don't go further with very invasive cardiac evaluation.
Yeah, I mean, it looks like diabetes again is not, is not a benign disease. So, and even the investigations in diabetic CKD patient completely different from non-diabetic as well. And the natural history of the disease as well in diabetic is different. Yeah. Thank you very much, Professor Fisser, for the comment. Yeah, but it's confusion, isn't it? It's all confusion here. Yeah.
Okay.
But this is what we have. You know, this is what we have. Yeah, just confusion.
Okay. Thank you.
Thank you. We have two questions more on the chat. What is the best time to transplant a case of recent PCI من أحمد مبروك الشيخ from Ahmed Mabrouk al-Sheikh? For how long we must wait, and when to DC anticoagulation, and how to anticoagulate the patient intra and post-operative? I think this needs a separate lecture. And
I mean, this is easy question. Easy to answer, because usually the cardiologist will put them on dual antiplatelet for 9 months.
Okay.
We don't operate on any patient with aspirin and clopidogrel. We wait for the cardiologist to wean one of them off. Usually they will wean the clopidogrel after 9 months and keep him on lifelong aspirin. We can operate on the patient on aspirin. And this is antiplatelet rather than anticoagulation. In terms of anticoagulation, if you mean patient on warfarin, so we have many patients on warfarin for various sort of reasons on our transplant list. We have what's called bridging protocol. Bridging protocol, basically when he comes in, we reverse his warfarin and wait for the INR to be 1.5, we operate, put kidney in, and then it depends on the risk. It depends on the risk of rebleeding. So we institute heparin later on, let us say 6 hours or to 12 hours after the operation. We monitor the drains, we'll leave the drains as they are. And then we institute warfarin on day 5. So in terms of anticoagulation, we follow a protocol as well. Anticoagulation, we involve the hematologist. And you see, we involve a lot of people in our management plan.
Okay, last question is about how to wait after cabbage before proceeding to transplant operation.
Sorry, how to
wait after cabbage before proceeding to transplant operation from Dr. Muhammad Ibrahim.
Fine. When he recovers and when he's cleared by the cardiologist. Because
yes, no exact time.
Yeah, I mean, basically, it's cabbage done by the cardiac surgeons and he's been followed by the cardiologist. Once the cardiologist feel he's fine from the cardiac point of view, this is why I refer back to the cardiologist again. You know, are you happy to go ahead? Yes, happy to go ahead. He's fit now. Then we transplant.
Okay.
The idea will be around the presence of the specialized person, cardiologist, physician, neurologist, whoever dealing with the current disease.
Okay, Professor Sobh, we have Professor Saeed Khamis and Professor Tariq Tantawi.
Okay.
Professor Saeed, please.
Listen to them now.
Professor Sobh, can you hear me?
Yeah, I hear you.
Yes.
Hear you.
Any comment, please?
We
okay,
listen to Dr. Saeed Khamis and Dr. Tariq Tantawi.
Yes.
Thank you, Professor.
Yeah.
Thank you, all professors, Professor Sobh, Professor Halawa, and Professor Yasser, and all my professors. Just one question, Dr. Halawa, regarding this decision of rejection of the patient based on that the patient, for example, has advanced heart failure due to very low ejection fraction, and in a case of potentially, let us say, amenable to amelioration or improving for this heart failure. For example, a patient starting dialysis and after a while, removal of this hypervolemia will improve the ejection fraction after a while, or a patient with a high flow fistula and you manage this fistula and the patient cardiac condition improved. Will you change your mind and re-evaluate this patient for transplantation again?
Definitely, 100%. I will tell you 2 stories. One patient presented to us in the clinic with edema up to his waist, and he was proteinuric.
Yeah.
And I was actually annoyed, honestly, with the nephrologist he referred him, because what I did, I referred him for dialysis. He was pre-dialysis. Hang on a second, you need to dialyze him, get fluid off, and give him medical nephrectomy because of the proteinuria. And I reviewed this patient 6 months later, transplanted 9 months later. Similar condition as well, echocardiogram with ejection fraction 32, and pre-dialysis fluid overload. We advise start on dialysis, we'll see you 6 months later. Usually these patients referred by junior staff, not the senior one. And once we discuss them in our MDT, we have a record of them, we have a follow-up of them, will be under our radar. As you mentioned clearly, fluid overload, ejection fraction ratio is poor, dialysis, taking fluid off, cardiac function improved, ejection fraction improved, we're put him on the list for transplantation. Of course, but there are few patients with no from the beginning, where they have a morbidity which is not correctable. Somebody who's intractable cardiac disease with ischemia and stroke and fully controlled diabetes, and he's 75 years old altogether. And some patients actually came for transplant. In addition to this, they are wheelchair bound. We consider this a review and discussion for transplantation rather than assessment for transplantation. Have a chat rather than assessment, because you can tell clearly is not clear, is can be cleared for transplantation and is not fit, and no further tests. Don't forget, when you start testing these patients, you will raise their hopes. They will think they could be transplanted. Everyone will always see what he wants to see, listen to what he wants to listen. This is us, human beings, always want to see what we want to see. We avoid raising hopes unnecessarily by being clear with the patients. If you start investigating, means there's a possibility. If you didn't start investigating, tell them you are not fit based on this is end of the story, finished. As I mentioned early on, correctable, we'll review the patient in 6 months' time and change our decision.
Thank you, boss.
Okay. So, Tantawi?
Thanks, Professor Halawa, for your elegant presentation and your amazing and confusing night at the same time. Actually, I'm enjoyed, and I think many aspects are covered well. And I think we need for further studies, further researches for that point that seem to us is clear, and actually it is not so clear. Waiting for the next presentation and the second part for your presentation, inshallah. كل سنة وانتم طيبين.
Thank you very much.
Mr. Ayman, we have no more questions and no more comments. And we are
but a lot of confusion, I believe. No more comments, but a lot of confusion.
Yeah.
we need it's very critical when we have so different situations, and sometimes a few conditions to make a good diagnosis in a patient with low cardiac output, and that sometimes he is waiting 10 years, and finally you have the kidney, and now what to do? We need to know and measure the risk that time.
Yeah, true. You know, this group of this population is quite difficult to deal with. Because, you know, if you look at the waiting list, you see that patients put on the waiting list, later on removed from the waiting list, then put back on the waiting list. When it becomes unfit, will be removed from the waiting list. When he gets better, we'll put back on the waiting list. When he gets unfit again, will be removed from the waiting list. This will tell you how difficult this disease is.
Okay, Professor Ayman?
Good.
No more now?
Okay.
Okay.
Very informative lecture and very informative discussions.
I think it's time to end this.
Professor Subh.
Yeah, I say this is very informative discussion and lecture, and thank you for all.
Could you repeat, please?
Thank you very much. Thank you. Thank you.
Thank you.
Thank you very much. Thank you.
Thank you. Excuse me.
I think I like to call this presentation stimulating rather than confusing. It's a stimulating lecture, actually.
I like this positive thinking, Dr. Ayman. Yeah, very positive thinking. Thank you very much.
Yeah, it's stimulating. It's not confusing. Thank you, and thank you. And we are waiting for the second part. That will be our next meeting, inshallah. The second part covering the other aspects of the dilemma and challenges in the transplant preparation, and to discuss other comorbidities. Thank you very much, Professor Halawa, and thank you very much, Professor Subh. Thank you, dear Professor Yasser, for your kind efforts, and thank you for all the professors and colleagues who shared with their valuable. Thank you very much, and see you in the second part.
Excuse me in the last to thank you all for this very stimulating night, and stimulating us to confuse, to think, to ask, to share. And as you can see, we cannot difficulty close this session after 2 hours, which is I think the longest session since we started our next year. And excuse me to close now and thank Professor Halawa for this highly elegant lecture. Thank Professor Muhammad Subh for being with us and supporting this meeting and this platform as usual, and Professor Ayman for the very fruitful meeting of transplantation chapters as usual. And we are waiting for more and more meetings and more stimulations and fruitful nights. Excuse me to close this night and this session and announce for the coming meeting. And as I promised in the last meeting, last Wednesday, we will have a specific session on iron therapy in hemodialysis, which will be in the next Wednesday by Professor Kamal Okasha at 10 p.m., which is our new date in only holy month of Ramadan. Next session will be iron therapy in hemodialysis patient by Professor Kamal Okasha.
Thank you very much. Thank you.
Thank you very much all, and thank you all professors who shared in this session by their comments, questions, and discussions. And excuse me to close this very fruitful meeting. And thank you. تصبحوا على خير. السلام عليكم ورحمة الله وبركاته.
Thank you very much. Thank you.
وعليكم السلام ورحمة الله.